Yeah, what you said was right. That's we will do that.
Right, right. So we'll start with the national program instead of the intensive care. So Kilkari is one of the national program for improving maternal and child health. What is the maximum age of beneficiary as a child under this program? So please type whoever knows the answer. The chat box is enabled, no, Kavita?
Yeah, you can't see it.
Yeah, I can. I hope they're able to. I mean, they were typing till now, no? They were typing the answers.
Yes.
So no answers. Take a guess, please. कोई बात नहीं, negative marks नहीं है इसमें. So yeah, 1 year, 2 years, 5 years. 5 years बहुत ज़्यादा है. Government इतना नहीं देगी. 1 year तक है. Children up to age of 1 year can actually covered under this. Okay. So just have a look at the recent whatever programs are being launched. Recently, prevention of congenital syphilis, vertical transmission of syphilis program has been launched and related to newborn and maternal child health. Okay. The second one, suspected intrauterine infection, III, which we call right now. The chorioamnitis term has been replaced by now III, intrauterine infection or inflammation. And it has certain criteria: fever without source in the mother, fever without source and purulent discharge from cervical loss, maternal leukocytosis, and one more factor. So what is that factor? When we look at the, yes, one is saying fetal tachycardia. Anyone else? Fetal tachy, 160. Yeah, someone is specific. Fetal tachy. Aniruddha is saying tachy, but whether it is maternal tachy or fetal tachy. So whenever you get an OSCE, just be specific. Otherwise, there all or none hota hai. Either you will get marks or you will not get marks. Maternal tachy. Maternal fever more than 38 is written. Maternal fever without source and 3 factors. Maternal fever is already there in the absolute criteria. So what is the third one? It's baseline fetal tachycardia more than 160 per minute for 10 minutes or longer, and it should exclude deaccelerations, accelerations, and periods of marked variability. So this is the third parameter, and do read up III. What is possible, probable, confirmed III? Yes, Poonam, that's right. Confirmed is amniotic fluid microbiology positive. So moving on to the third one. What was the theme of Breastfeeding Week 2022? When is it celebrated? Breastfeeding Week? Anybody guesses about the week? Not September, yeah. August 1st to August 7th, that is right. So every year they give a theme, no? So whenever you go for exam, just have a look. I purposefully am putting these right topics for you. Step up for breastfeeding, educate and support. Yeah, right, Shraddha. Something related to support. So just read it up, okay? Can we move on to the next question? Step up for breastfeeding. Yes, Karthike, good. So breastfeeding is very, very important. In between the ventilation and intensive care, do not forget the basic things, right? So do keep a watch on breastfeeding programs also. The term aggressive posterior ROP has been replaced by which term as per the new recommendations by ICROP, no? So there are certain changes which are given by retinopathy of, yeah, yes. Any other answer? Vinod and Monica have given. Anyone else? Yes. So now the term posterior has been removed. It's only aggressive ROP. You're rightly said. I think the answer not visible, but it is aggressive ROP. Why? Because now it is lately being seen that not only posterior, but it can happen in the other zones as well, where the vessels are actually tortuous and progressing rapidly. So instead of posterior, it's now only aggressive ROP. So this is a formula for calculation of osmolarity. So what is the missing parameter in this? Sometimes we do need to calculate osmolarity whenever urea, 1, urea. So is blood urea nitrogen is the answer, not urea. So the one who has written BUN will be getting.
એના પર જ પૂછી લેતે જે વાંચ્યું તે તો meningitis ને કઈ તો પૂછ્યું જ નથી.
What does this graph
આનું
represent?
રિલેટિવ્સ મને પૂછે છે મેં કીધું કે મને આઈડિયા નથી મળતો કે
What does this graph represent? No, what is the abnormality in this graph? Is it okay? Very good, just jolly. That is slow starvation, inadequate flow or air hunger. So whenever you see an 8-shaped graph, leaks and compliance, you all are aware of the PV loops. So whenever you see a 8 figure like this, it indicates inadequate flow, air hunger. Next question. This is a theoretical question, and sometimes we do need to know these things. At 15 to 20 weeks of gestation, definition of increased nuchal fold thickening is more than how much? Just take a guess, because antenatal parameters are important, including the triple screen, quadruple screen, what's the sensitivity, how to interpret that screen. So what are the soft markers? How would you counsel them? So for that purpose, you should know. Okay, everybody is giving ranges to 5 mm. So it's 6 mm. So it's specific for this gestation, 15 to 20 weeks, and it's 6 mm. Arvind Reddy has answered. Okay. So in the last fellowship exam also, there was a question on this consensus management of developmental dysplasia of hip. The minimum age at which X-ray is recommended as per the most recent consensus statement by Pediatric Orthopedic Society, IAP and NNF. What is the minimum age at which they say that X-ray is useful? Do read that up, especially the NNF and the IAP consensus guidelines. No, it's not 6 weeks. 14 weeks. 14 weeks. START guidelines are for reporting of which type of studies? Statistics. Take a guess. Consort, you know, Prisma chart, you know. So what is for? Take a guess, which type of studies? No? So the START guidelines, so just click on the equator network, and there is a list of all these guidelines for which type of study you need to apply which guideline. No, you give a list, just have a glance or take a print or something like that, just to have just you can score in the OSCE, something like this happens. Okay? So for case reports, you see there is CARE. For diagnostic and prognostic test, you have START. For study protocols, you have SPIRIT. Systematic reviews, you all know Prisma. For observational studies, we have STROBE. For RCTs, we have Consort. So just have a look at these. So identify this device. Anybody? Yeah. This is Piccolo device for PDA closure in extreme preterms. Okay, so new device Piccolo. So what does this formula indicate? Look at it carefully and then tell me what is this? Which index is this? So read the question carefully whenever you give the exam. It's not OI. Is it divided by SpO2 or PaO2? The denominator is not PaO2, it's SpO2. So it's oxygen saturation index, OSI. Yeah, those who have written OSI is correct. So this is a clinical question. Just I'll just read it out for you. It's a term neonate born through meconium strain. Ventilation is on high frequency mode. Map of 16, amplitude of 28, FiO2 of 100%, and frequency of 8 Hertz with an TI of 33%. So blood gas shows pH of 7.12, PCO2 of 70, PO2 of 80 and base excess of -2. Saturations are okay, 96%. So after you ensure all the other supportive care, which parameter of the ventilation would you change after seeing this ABG? Give you some time. So do read up HFO in case your units are using HFO and intensive care case अगर मिलता है तो do read it up because frequency इसमें opposite direction चलता है. So whoever is in writing increase frequency, that is wrong. So either you increase the amplitude or reduce the frequency. And here already if the frequency is 8, so I would say that the first action would be increase the amplitude. And in HFO, oxygenation and CO2 elimination are delinked. So they are separate, unlike in conventional. So if you are using HFOs in your unit, do be familiar with the parameters and the knobs and which one will you touch when, okay? So this is regarding antenatal hydronephrosis. It's a term baby, birth weight of 3,200 grams. Serial antenatal ultrasound showed bilateral hydronephrosis with right renal AP diameter of 6 mm and left renal diameter of 8 mm. SFU grading was 1 and there were no features of lower urinary tract obstruction. The baby is active, alert and passed urine after birth. So which day of life should the postnatal ultrasound be done in this case? If a baby presents to you, yes. Right. So you all of you should be aware of this very well made flow chart. It's available everywhere, SFU grading. And then based upon that, how would you manage? So it should be done anytime after 48 hours. And it's not an emergency because there are no signs of lower urinary tract obstruction in this case. So I think most of you have got it right. Identify this chart and where is it used? Just take guesses. No, I'm waiting for a few seconds more. No. थोड़ा अलग है मेटा एनालिसिस से. So it is a control chart. It's a form of what to say. These are the runs and the run charts. They are used in qualitative studies, quality improvement studies to be specific. So quality improvement studies, quality improvement initiatives, run charts, just be aware of that because these are the upcoming strategies to improve implementations in the units. So we have an upper control limit. UCL is upper control limit, LCL is lower control limit. Then we have plotted the runs here and we chart the limits and then we analyze. So these are the control charts and they are used in quality improvement studies, not in meta-analysis. So which graph is this? Which nomograms are these? 97th centile, 4 mm above 97th centile. Today case was also presented. I'll just give you a clue. You must have charted it in this one. Yeah. So it is a Levy nomogram and which plane of the cranial ultrasound, which view do you measure it? If anybody does bedside ultrasounds. Any guesses? No. It's done in the coronal view, not in the sagittal view, coronal. Yeah. So yeah, that's the end of the OSCE. I think well done. Few were answering, but whoever answered, they were doing well. Do read up the programs and do read up the days. So some examiners may ask that. Yeah, Dr. Kavita, over to you, please.
Thank you, Dr. Pratima. I think such a fun OSCE and so useful in terms of exams. So I think we just will end the session here. And I thank Dr. Pratima for taking the case discussion and also the OSCE, and I thank all the presenters and the students. So we'll end the session. Thank you.
Thank you, everybody.
Yeah, thanks.